Think about this. Over 200 million people around the globe are affected by a condition you might not hear much about, peripheral arterial disease.
PAD, yeah.
And in the last 10 years alone, the number of cases has shot up by a staggering 25%. It's a major global health problem we're diving into today.
Exactly. And to really get to grips with this, we've turned to, well, the definitive resource. Chapters from the 10th edition of Rutherford's Vascular Surgery and Endovascular Therapy.
The gold standard.
Pretty much. So we're getting really reliable information here.
And our goal today, for you who shared this incredibly detailed material with us, is really to pull out the essential understanding of this lower extremity arterial occlusive disease, PPA affecting the legs and feet.
Make sense of it all.
Yeah, highlight what's most important for you to know. So let's get right into it. What exactly is PAD?
Okay, so in simple terms, PAD is a long-term condition. The arteries in your legs get narrowed or blocked.
Oh.
Usually it's atherosclerosis, that's plaque, buildup, fat, cholesterol, other gunk inside the artery walls.
Like rust in a pipe.
Sort of, yeah. It makes it narrower, harder for blood to flow. But what's really interesting is how tricky it is to get a precise count of how many people actually have PAD.
Why is that?
Well, many people have it early on, or their symptoms are a bit atypical, not the classic stuff. And we don't routinely screen everyone, like with the ankle brachial index, the ABI test.
Right, no universal screening. So if we don't have that, how do we figure out how common it is?
We piece together the picture from specific screening studies, research projects, also from data on people who do have clear symptoms like intermittent claudication.
That's the leg pain when walking, right?
Exactly. Comes on when you walk, goes away with rest. And we also look at how often PD shows up in people with related conditions like diabetes or those who've unfortunately had amputations.
You mentioned that huge global number, over 200 million. Is it growing everywhere?
Pretty much, yeah. It's increasing in high-income countries, HICs, and low- and middle-income countries, LMICs.
Right.
But the growth rate is definitely faster in LMICs.
Really? Where's specific?
Particularly noticeable in the Pacific Rim and Southeast Asia.
Huh. Are there differences based on, say, gender or age?
Globally, yeah, the patterns vary a bit. In HICs, it seems to hit men and women about equally. And it gets much more common with age, like less than 5% under 50, but jumps to maybe 20% for folks over 80.
Wow.
But in LMICs, some studies suggest women might actually have higher rates in certain age groups. It's an area we still need to understand better.
Okay. And what about here in the U.S.? What's the picture like?
In the U.S., estimates are around 8.5 million adults with PAD. And similar to other high-income countries, there's that really strong link with age.
Over 20% for the over 80s again.
Yeah, that's right. There was a study, 2003 to 2008, I think. It estimated about a 2.35% annual incidence in insured folks and overall prevalence around 10.69%.
So nearly 11% prevalence in that group. Now, what about those specific stages people might experience, like the claudication or CLTI?
Right. Chronic limb-threatening ischemia, CLTI. That's also tough to count accurately. Intermittent claudication, that classic leg pain, is maybe up to 6% of people over 65 in Western countries.
But you said symptoms can be atypical.
Exactly. So that 6% could easily be an underestimate, Many patients have leg pain that doesn't quite fit the textbook description.
And CLTI, the really severe stage.
Yeah, where blood flow is critically low. Studies report incidence rates anywhere from 0.02% to 0.35%, and prevalence maybe 0.3% to 2% in different adult groups.
So in the U.S., that could be, what, a couple of million people?
Potentially, yeah, around 2 million. It's a significant number dealing with that severe end of the spectrum.
Okay, so we have a sense of how widespread it is. What actually makes someone more likely to get PAD? What are the risk factors?
Well, the key thing to remember is that PAD is usually part of this bigger picture systemic atherosclerosis.
Meaning it shares risk factors with heart disease and stroke.
Exactly. Many of the same players are involved, but the importance of each factor can differ a bit for PA compared to, say, coronary artery disease.
Got it. So let's break those down. What about demographics?
Age, that's the big one, really stands out as the strongest risk factor. PA is pretty rare under 40, but the risk climbs steadily, especially into the 60s, 70s, and like we said, over 80.
Okay, age is key.
Yeah.
Anything else demographic?
Yeah, something really important and frankly not fully understood is the difference observed between Black and white populations. Yeah. Studies consistently show higher rates of PA and often worse outcomes for Black individuals. And this difference isn't completely explained by the traditional risk factors we usually look at.
That's concerning. What about lifestyle things like smoking?
Huge factor. Smoking is a very powerful, very independent predictor. Smokers generally have like a 2 to 4 times higher chance of developing PA.
2 to 4 times, wow.
Yeah. And there's even some suggestion, though maybe needing more research, that secondhand smoke could also increase risk.
Okay. And diabetes. We know that's bad for blood vessels generally.
Absolutely. Diabetes is strongly linked, both to how common PAD is and how severe it gets. The risk increase is similar to smoking, that 2 to 4-fold range.
And does it get worse with age or duration of diabetes?
Yes, particularly with older age and having had diabetes for a longer time. And the combination, oh boy, diabetes and smoking together, that's especially dangerous.
How so?
It dramatically ramps up the risk of severe PAD, amputation, even death. Studies clearly show diabetes negatively impacts long-term outcomes, lower survival rates, and a 5-fold higher risk of limb loss compared to PAD patients without diabetes.
5-fold. That's significant. What about common things like high blood pressure or cholesterol?
High blood pressure, hypertension, it's common in people with PA, definitely. And studies show a link. But the independent association, when you account for other things like age, seems a bit weaker than it is for smoking or diabetes.
Interesting. And cholesterol?
Dyslipidemia, yeah. Elevated total cholesterol and lower levels of the good cholesterol, HDL, are associated with PO in many studies. Actually, the ratio of total cholesterol to HDL seems like a pretty strong predictor.
What about the bad cholesterol, LDL?
The link there is less consistent, surprisingly. And unlike for heart disease, we don't really have specific LDL target numbers for treating PAD alone.
Okay. What about obesity?
The evidence there is a bit mixed, inconclusive really for obesity just based on BMI. Some studies hint at maybe a U-shaped relationship risk at low and very high BMIs.
No, not straightforward.
Doesn't seem to be. It might be more about where the fat is. Central obesity, more fat around the middle, that's often linked with metabolic syndrome and diabetes, and that seems more relevant to PAD risk than just overall weight.
Gotcha.
Yeah.
We've covered the usual suspects. Are there other factors, maybe less common ones, like inflammation or homocysteine?
Yeah, inflammation definitely plays a role. Higher levels of inflammatory markers in the blood, things like C-reactive protein, fibrinogen, they're consistently linked with atherosclerosis generally, and PAD specifically.
Does it relate to severity?
It does. These markers are often higher in people with more severe PAD and worse outcomes. Patients with CLTI, that limb-threatening stage, tend to have the highest levels. There are other biomarkers being looked at, but their clinical usefulness isn't clear yet.
And homocysteine, I've heard that mentioned.
There is a statistical link found in some studies with elevated levels, yeah. But the association tends to weaken quite a bit when you properly control for other risk factors. And interestingly, clinical trials giving folate supplements to lower homocysteine haven't really shown consistent benefits for PAD.
Okay, one last area, socioeconomic status. Does that play a part?
It seems to. PAD has been linked to lower socioeconomic status, things like lower income, less education.
Across different groups.
Yeah, seen across racial and ethnic groups. And it's not fully explained just by differences in those traditional risk factors we discussed.
So what else could be going on?
Well, research, like the Weir study, found that income, education, even living in disadvantaged neighborhoods were strong predictors of needing hospitalization for advanced PAD, even after accounting for other factors and healthcare access. It suggests things like maybe chronic stress, health literacy, nutrition, they could all be playing a role too.
Right. Okay, so that gives us a really good picture of the risk factors. Now, where in the legs and feet does PAD typically show up? And how does that connect to what patients actually feel?
Good question. Anatomically, we often describe it by levels based on the main arteries involved. You've got the aortoiliac arteries that's up in the abdomen and pelvis.
Okay.
Then the femoropopliteal arteries, thigh and behind the knee. And finally, the tibiopetal arteries, lower leg and foot.
And do certain risk factors point to certain locations?
It seems so, yeah. For instance, smokers seem more prone to blockages in the aortoiliac and femoropopliteal segments, whereas diabetes is more strongly linked to problems down lower in the tibiopetal and also the femoropopliteal arteries.
And how does that location then translate into symptoms?
There's a pretty clear connection. Intermittent claudication, that exercise pain, Usually happens when there's significant narrowing higher up in the aortoiliac and/or femoral arteries, often just in one segment.
Okay.
But CLTI, the chronic limb-threatening ischemia, that typically involves blockages in at least two major segments or really severe disease just in those lower tibiopedal arteries.
Why the difference?
It often comes down to collateral pathways. If you only have a blockage in one spot, especially higher up, the body can sometimes develop these little detours for blood flow.
Oh, workarounds.
Kinda, yeah. Imaging studies back this up. Smoking linked to AIFP disease, diabetes more to FPTBP, and there are other associations to disease higher up, like aortoiliac tends to link with younger age, smoking, and being male, while the lower tibiopedal disease is more tied to diabetes and advanced age.
Makes sense.
Yeah, and in one study looking specifically at CLTI patients, over half had blockages either behind the knee, the popliteal artery, or in those tibiopedal arteries.
Yeah.
And this was especially common in folks with both diabetes and kidney failure.
Okay, so PAD isn't just one thing, it shows up differently. What are the main clinical syndromes, the different ways it presents?
Broadly, we can categorize it by presentation. Some people are asymptomatic, they have PAD but no symptoms.
Right.
Others have leg symptoms, but they're not that classic claudication pain. Then you have intermittent claudication itself. And finally, the most severe form, CLTI.
And their staging systems.
Yes, doctors use formal scoring systems like the Fontaine classification and the Rutherford classification. They use clinical descriptions and objective measurements like the ABI to stage the disease. These help guide treatment and predict outcomes, though there's ongoing work to refine these, especially for that really severe limb-threatening end.
Let's start with the asymptomatic group. How common is that? And should people worry even if they don't feel anything?
It's actually the majority. A significant number of people found to have PAD on testing don't report any symptoms.
Why not?
Could be several reasons. Maybe the blockages aren't that severe yet, or they have really good collateral blood flow compensating, or maybe they just aren't very active because of age or other health problems, so they don't push themselves enough to feel it.
But is it still a problem if they don't feel it?
Absolutely, yes. This is crucial. Even without symptoms, asymptomatic PAD carries a significant risk, higher risk of cardiovascular events, heart attack, stroke, and an increased risk of death overall.
Really? How much higher?
Studies show considerably higher overall mortality, maybe 2.7 times greater, and even higher risk, like 5.6 times, of dying specifically from coronary artery disease compared to those without PAD.
Wow. So finding it early matters, even without symptoms.
Yes, because identifying it allows for managing those cardiovascular risk factors aggressively. And interestingly, it's not just a low ABI that signals risk. A very high ABI, over 1.4, which can indicate stiff arteries, is also linked to increased mortality and CV events.
So even if you don't feel the PAD in your legs, it's impacting your overall health.
Definitely. Research shows people with asymptomatic PAD often have reduced physical function. They tend to become less active over time.
How so?
Things like slower walking speed, not being able to walk as far in tests, like the 6-minute walk test. And these changes seem linked to actual changes in the calf muscles. Less muscle mass, more fat infiltration, and also problems with nerve function in the legs.
Can that be reversed?
We don't really know yet if those muscle and nerve changes are reversible with treatment. And while many stay asymptomatic, there's still a risk of progression. Maybe around 7% are estimated to develop actual intermittent claudication symptoms within about 5 years.
Okay, now let's move to intermittent claudication, that classic recurring leg pain with exercise. How's that usually diagnosed?
Right, I see. It's characterized by that predictable leg pain, usually in the muscles, that starts with exercise like walking and reliably gets better when you stop and rest.
Need to rule out other things, I guess.
Oh, for sure. It's important to differentiate it from other causes of leg pain, maybe nerve issues from the spine, vein problems, arthritis in the joints, or other muscle conditions. Doctors often use specific questionnaires in research, like the Rose or San Diego questionnaires.
And in the clinic.
Usually a careful history, asking the right questions, plus a physical exam, and those simple non-invasive tests like the ABI, that's enough for diagnosis. But again, remember, many PAD patients have leg symptoms that aren't quite that classic pattern.
Where do people typically feel claudication pain? What part of the leg?
It can be higher up buttocks, hips, thighs, or more distally in the calf muscles. Calf pain is by far the most common.
Does the location give clues?
Often, yes. It reflects where the blockage is likely located proximally. So aortoiliac disease might cause buttock, hip, or thigh pain, maybe along with calf pain. Femoral disease usually just presents as calf pain with exercise.
What about disease really low down, below the knee?
Interestingly, disease limited to just the tibiopedal arteries often doesn't cause typical claudication, though sometimes people might feel pain in the muscles of the foot itself when walking.
And how do doctors gauge how severe the claudication is?
Usually by how far someone can walk before the pain forces them to stop. That's the initial claudication distance, or sometimes the absolute claudication distance. People with really severe IC might not even be able to finish a standard treadmill test.
That must really impact their lives.
Oh, hugely. Significant limitations in daily activities, reduced quality of life. They just have to stop walking very quickly. And functional tests show they often have reduced strength, balance, overall mobility, too. And these things can sadly worsen over time related to PA severity, age, and other factors.
We talked about the heart risks with asymptomatic PAD. Is it similar for people with claudication?
Yes, the long-term cardiovascular risks are also significant for people with IC. Over 5 years, maybe 20% will have a major CV event, heart attack, stroke. And the risk of dying in that period is around 10–15%.
Is that higher than, say, just having heart disease?
Some evidence actually suggests that having symptomatic PAD, like claudication, might be even more strongly linked to these bad outcomes than having known coronary or cerebrovascular disease alone.
Yet they might not get treated as aggressively.
That's a consistent finding, unfortunately. Studies show PAD patients, including those with just claudication, are often undertreated compared to patients with other forms of atherosclerosis when it comes to risk-reducing meds like antiplatelets or statins.
What about the outlook for their legs specifically? Does claudication often lead to amputation?
Generally, the limb prognosis for most IC patients is considered relatively benign, thankfully. But a significant minority, maybe around 21% based on one review, do experience worsening symptoms or limb threat over 5 years.
When does that worsening usually happen?
It seems the most significant decline often occurs within the first year after diagnosis, but the actual risk of needing a major amputation remains quite low, estimated at less than 1% per year for IC patients.
What makes someone more likely to progress from IC to something worse?
Pretty much the same factors that caused the PD in the first place. But diabetes, and especially continued smoking, really stand out as driving progression towards CLTI.
Okay, let's talk about that most severe form. Limb-threatening ischemia. You mentioned acute versus chronic.
Right, it's crucial to differentiate them. Acute limb ischemia, ALI, is a sudden dramatic drop in blood flow to the limb, usually happens over less than 2 weeks.
What causes that sudden drop?
Could be a clot forming right there in a narrowed artery, thrombosis, or a clot traveling from elsewhere, like the heart embolism or trauma, or even a tear in the artery wall.
And the outlook for ALI?
It's serious. High risk of major amputation, maybe 10–15%, and unfortunately high mortality too, 15–40% within a year. Risk factors for ALI include having had previous bypasses or stents, a very low ABI, and conditions like atrial fibrillation. And remember, ALI can sometimes happen in someone who already has underlying PPA.
Okay, so that's acute. What defines the chronic version, CLTI?
Chronic limb-threatening ischemia, CLTI, used to be called critical limb ischemia, CLI. It's the advanced stage where there's ischemic rest pain in the foot, even when resting, or tissue loss, like an ulcer that won't heal or gangrene. And importantly, these have to be present for at least 2 weeks.
Why the name change from CLI to CLTI?
It's seen as more inclusive. It acknowledges that nerve damage, neuropathy can sometimes mask the rest pain, so relying solely on pain isn't enough. Also, defining absolute critical blood flow numbers that apply to everyone is hard. Chronic also helps separate it clearly from that sudden ALI picture. It implies insufficient flow to meet the limb's basic metabolic needs.
Are there specific measurements like ABI or toe pressures used to diagnose CLTI?
Historically, yes, but the thresholds have varied a bit. Generally, for rest pain, you might see an ankle pressure below, say, 40 or 50 mmHg and a toe pressure below 30 mmHg. For tissue loss, the numbers might be slightly higher, maybe ankle pressure below 50–70 mmHg, toe pressure below 40–50 mmHg.
And the staging systems fit in here.
Right. Fontaine and Rutherford classifications have stages for rest pain and tissue loss. Rutherford even subdivides tissue loss into minor and major, though that major definition hasn't always been consistent in research, which made comparing studies difficult. That's partly why newer systems like WIFI were developed.
How common is CLTI compared to, say, claudication?
It affects a smaller slice of the PID population. Estimates range maybe 1% to 10%. Some studies found around 1.3% prevalence in insured U.S. adults, maybe 0.5% to 1.2% in older Swedish adults.
Some more risk factors.
Generally, yes, but you see an even higher prevalence of diabetes and kidney disease among CLTI patients. And interestingly, a lot of people who present with CLTI don't actually have a prior history of classic claudication.
Why would that be?
Several possibilities. Maybe their disease is mainly below the knee, which causes less claudication, or coexisting neuropathy masks the pain, or they might have low mobility from other issues. Or sometimes it's triggered more acutely by minor trauma or a foot infection in someone with underlying PI. Really highlights the need for careful foot exams.
What's the prognosis like for someone diagnosed with CLTI? Sounds serious.
It is, unfortunately. The prognosis for both the limb and the patient's overall survival is quite poor. These patients often have widespread cardiovascular disease, high risk for heart attack, stroke, death, and amputation.
Are there numbers on that?
One review looking at sort of the natural history if left untreated suggested about 22% mortality and another 22% major amputation rate within just 1 year. Now, that's a bit theoretical because most do get interventions like revascularization these days.
But still highlights the risk.
Absolutely. Because the risk is so high, there's been a lot of work trying to predict who's most likely to die or lose a limb. Looking at factors like age, kidney failure, heart disease, diabetes, tissue loss severity, functional status, frailty.
And that's where the WIFI system comes in.
Exactly. The Society for Vascular Surgery developed it. WIFI stands for wound, ischemia, and foot infection. It aims to be a more consistent, standardized way to stage the threatened limb.
How does WIFI work?
It grades each of those three components: the wound characteristics, the degree of ischemia, lack of blood flow, and the severity of any foot infection on a scale, typically 1 to 4. Combining those grades gives you an overall clinical stage from 1 to 4.
And does that stage predict outcomes?
Yes, studies have validated it. The WIFI stages correlate pretty well with the estimated 1-year risk of amputation and also with wound healing outcomes. It helps the doctors risk stratify patients, identify who's at low versus very high risk, and maybe even predict healing times and costs.
This all really underscores how important it is to catch PI early. Which brings us back to screening. Should everyone just get an ABI test?
That's a million-dollar question, and it's controversial. The ABI test itself is simple, non-invasive, not too expensive. But the U.S. Preventive Services Task Force looked at the evidence for population-wide screening.
Wow.
They concluded there wasn't enough evidence to say the benefits clearly outweigh potential harms or costs for screening everyone without symptoms. A more recent systematic review basically agreed.
So no mass screening.
Current SVS guidelines recommend against general population screening. However, they do suggest that targeted screening might be reasonable for specific high-risk individuals.
Like who?
People over 70, maybe, or those with diabetes, if finding PA would actually change how their overall cardiovascular risk is managed or influence their therapy.
What do other groups say? AHACC.
Similar idea. They recommend considering ABI testing in asymptomatic folks who are at increased risk. That includes age over 65, age 50-64 if they have other risk factors like smoking or diabetes or a family history of PED, anyone over 50 with diabetes plus at least one other risk factor, or anyone who already has known atherosclerosis elsewhere, like in their heart arteries or carotid arteries.
So targeted screening in high-risk groups. But not for everybody.
Okay.
So if someone is diagnosed with PA, what kind of follow-up or monitoring do they need?
Well, for those with asymptomatic PA, the benefit of, routine annual surveillance isn't really established, but it's vital they and their doctors are aware of the diagnosis and know the signs if things get worse.
Especially foot care.
Definitely. Regular foot exams and education on self-care are crucial, especially for those with diabetes or anyone who's ever had CLTI.
What about people with symptoms like claudication?
Patients with symptomatic PAD, confirmed by tests, are typically followed long-term to watch for worsening. For mild to moderate IC, the first steps are usually lifestyle changes. Stopping smoking is huge, plus medical management, maybe statins, antiplatelets, and ideally a supervised exercise program.
And if that doesn't work?
Then revascularization procedures might be considered for more disabling symptoms. The SVS recommends annual follow-up for all IC patients. That should include a clinical exam and an ABI test to check for progression and see how well they're managing.
What about after procedures like bypass or stents?
They generally need closer monitoring, yeah. That includes surveillance of the vascular reconstruction itself. There's decent support for using duplex ultrasound to monitor vein bypass grafts.
Less clear for other types.
The benefit of routine surveillance for prosthetic grafts or after endovascular procedures like stents is less certain, but it's still commonly done in practice. These follow-up visits, maybe semi-annually or annually, should always include checking their functional status, asking about symptoms, and a really thorough foot exam. So yeah, as we've kind of unpacked here, PAD is really a significant and growing health issue around the world. It shows up in lots of different ways, driven by a whole range of risk factors.
And it seems clear that finding it early, managing those risks, is crucial, even if someone doesn't have obvious symptoms yet, right?
Absolutely. Understanding the different syndromes, asymptomatic, IC, CLTI, and using tools like the WIFI staging system, that's all vital for figuring out the prognosis and the best treatment path.
This deep dive, really drawing from the top experts via Rutherford's, should give you, our listener who shared this, a much clearer grasp of PAD based on that comprehensive material.
Which, brings up a really interesting point to think about further. We know even asymptomatic PAD carries significant cardiovascular risk, but there's this debate about broad screening. So what are the wider public health implications? How do we best approach early identification and intervention for those high-risk populations? It's definitely a big question with real societal impact beyond just the clinic.